Okay, hi everyone. I think we're going to go ahead and get started. It looks like it's 3 p.m. Eastern Standard Time. Thank you all for joining today. I just wanted to take a minute to welcome everybody to our August Neurocritical Care Society Pharmacy Section Journal Club. My name is Kristen Sloan. I work at San Francisco General Hospital, and I will be your primary moderator for today's journal club. I'm also joined by Megan Vallejo, who is my co-moderator today. And I also wanted to take a minute to thank Megan for her mentorship. This is my first time facilitating and moderating an NCS Journal Club, and she's provided some great guidance to me in this process. Additionally, we're also joined by Alex Connery today, and he will be our Twitter moderator for this session. If Twitter is your preferred platform, you can join us on Twitter or Twitter X, and our hashtag for that is NCS PharmJC, and you will see Alex there. We have the pleasure today to be joined by two critical care PGY2 pharmacy residents who will be presenting the Journal Club articles today, Alyssa Beyer and Nicole Castoro. So we thank you for your preparation for this presentation today. Before we get started, just to cover a few logistical issues, if you can please take a minute and make sure that you are on mute so that we do not interrupt our presenters during the presentation. After each presenter presents their Journal Club article, there will be about 5 minutes for questions. You're welcome to unmute at that time and ask your questions, or if you have questions throughout the presentation, you're welcome to put them out in the chat function, and we can address them during the question portion of today. With that, I'm going to introduce our first presenter for today. Our first presenter for today is Alyssa Beyer. She's a PGY2 critical care pharmacy resident from Tufts Medical Center. She will be sharing with us today a randomized control trial evaluating localized nicardipine release implants for prevention of vasospasm after aneurysmal subarachnoid hemorrhage. So Alyssa, feel free to get started.
Can everyone see my screen okay?
Yes, we can see it.
All right, then I will get started. So thanks everyone for being here today. As mentioned, my name is Alyssa Beyer, and I'm the PGY2 critical care resident at Tufts Medical Center in Boston. Today, I will be discussing the article, Localized Nicardipine Release Implants for the Prevention of Vasospasm After Aneurysmal Subarachnoid Hemorrhage. And before we start today, here are some abbreviations that I will utilize going forward in today's presentation. Learning objectives for today. So after today's presentation, you should be able to describe the common complications that often ensue after aneurysmal subarachnoid hemorrhage, compare nicardipine and nimodipine specifically regarding their pharmacology and place in therapy according to the AHA and ASA guidelines and pertinent primary literature, and lastly, interpret the findings of the study presented today. First, I will be discussing some background information to set the stage for the study at hand today. Starting with epidemiology. In 2010, an aneurysmal subarachnoid hemorrhage occurred in about 6.1 out of 100,000 people. In 2020, the global prevalence reached about 8.09 million cases. And by the end of 2012, the pre-hospital mortality reached up to 26%, with up to 2/3 of survivors needing lifelong care. Some risk factors for subarachnoid hemorrhage include patients who smoke cigarettes, who use cocaine, have a first-degree family member with a history of subarachnoid hemorrhage, patients with hypertension, specifically uncontrolled, and patients with heavy alcohol use. Additionally, women have a 1.6 higher risk than men, and Black patients have a 2.1 time higher risk than white patients. The classic sign of an aneurysmal subarachnoid hemorrhage in an awake and alert patient is a headache that is sudden in onset and immediately reaches maximal intensity. In patients with a severe headache, the Ottawa rule is a highly sensitive screening method that can rule out individuals with a low likelihood of subarachnoid hemorrhage based on these criteria. Other symptoms patients may present with include nausea and vomiting, neck pain, and photophobia. On physical exam, patients may have retinal hemorrhages, meningismus, a diminished level of consciousness, and localizing neurologic signs. As far as radiological diagnosis, subarachnoid hemorrhage can be detected by high-quality CT scan with a high sensitivity and specificity, especially when done within 6 hours of symptom onset. A lumbar puncture may be indicated if a non-con CT is unrevealing and there is still a suspicion of subarachnoid hemorrhage within 6 hours of symptom onset. CTA or CT angiography is another widely available diagnostic tool for subarachnoid hemorrhage if both a non-con CT and LP are unrevealing, but ultimately DSA or digital subtraction angiography is the gold standard to diagnose or exclude aneurysmal subarachnoid hemorrhage. Additional monitoring tools include TCD or transcranial Doppler. This is a non-invasive and safe bedside neuromonitoring technique that allows the repetitive and dynamic assessment of vasospasm after aneurysmal subarachnoid hemorrhage with a high sensitivity. There are various clinical scales that are recommended for both determining the initial clinical severity and for predicting outcomes, including the Hunt and Hess World Federation of Neurosurgical Societies and the Modified Fisher Scale. Very briefly to touch on the first and last, the Hunt Hess classifies patients based on symptoms to predict mortality, while the Modified Fisher Scale is a radiological grading system that assesses the risk of symptomatic vasospasm in patients. And the WFNS grading scale, which is the most relevant to the study we will discuss today, takes into account both level of consciousness according to GCS and the presence or absence of aphasia and or hemiparesis as prognostic factors. As the grade increases, the severity of subarachnoid hemorrhage is increased and survival decreases. For patients who do survive initial aneurysmal rupture, there are complications that may follow that are of major concern, such as cerebral vasospasm, which is defined as cerebral arterial narrowing that is seen via radiological tests, DCI, which is defined as focal neurologic deficits or a global neurologic deficit that lasts for at least 1 hour and or with new cerebral infarcts on imaging. These first two occur typically between days 4 and 14 after bleed. And the bottom two include hydrocephalus and seizures. Currently, there are no guideline recommended therapies for the prevention of cerebral vasospasm. The AHA and ASA guidelines do, however, recommend the following for prevention of DCI, which include oral nimodipine, maintenance of euvolemia, elevation of systolic blood pressure in the setting of symptomatic vasospasm, intraarterial vasodilator administration for severe vasospasm, and cerebral angioplasty for severe vasospasm. The recommendation for oral nimodipine for prevention of DCI comes from the following multicenter, double-blind, randomized controlled trial that assessed 554 adult patients with aneurysmal subarachnoid hemorrhage that occurred within the past 96 hours. Patients were randomized to receive nimodipine 60 milligrams by mouth every 4 hours versus placebo for 21 days. Patients in the treatment group had decreased rates of infarction, poor outcome, rebleeding, and mortality compared to placebo. Additionally, IV nicardipine has been studied in patients with aneurysmal subarachnoid hemorrhage. This study was a multicenter, double-blind, randomized controlled trial that assessed 906 adult patients that were diagnosed with aneurysmal subarachnoid hemorrhage within the past 7 days. Patients were randomized to receive nicardipine dosed anywhere from 0.01 to 0.15 milligrams per kilo per hour versus placebo for up to 14 days. Notable outcomes include patients in the nicardipine group had decreased incidence of death and disability due to vasospasm compared with placebo. However, this group also had higher rates of adverse events compared to the placebo group. On this slide, I've included a table comparing nicardipine and nimodipine. Both medications inhibit calcium from entering select voltage-sensitive areas of vascular smooth muscle during depolarization, but nimodipine has a greater effect on the cerebral arteries. Dosing for nicardipine is as follows. It ranges from 0.01 to 0.15 milligrams per kilo per hour IV. Intraarterial dosing ranges from 1 to 5 milligrams, and intrathecal from 2 to 4 milligrams every 8 to 12 hours. Nimodipine is dosed 60 milligrams by mouth every 4 hours for 21 days. The onset of IV nicardipine is within minutes and lasts up to 8 hours. It has an alpha half-life of 3 minutes and beta of 45 minutes and is lipophilic. Nimodipine's onset of action is between 30 minutes to 1 hour. Its bioavailability is 13%. It's metabolized via CYP3A4 and has a half-life of 1 to 2 hours. And lastly, both medications have common side effects, including hypotension, tachycardia, GI distress, and headache. As for surgical intervention, the AHA and ASA guidelines recommend clipping in patients who are less than 40 years old and in good grade aneurysmal subarachnoid hemorrhage, which is defined as a Hunt-Hess score of 1 to 3, from ruptured aneurysms of the anterior circulation that are equally suitable for either. They recommend coiling in patients with ruptured aneurysms of the posterior circulation, and either is preferred in patients greater than 70 years old and in good grade aneurysmal subarachnoid hemorrhage from ruptured aneurysms of the anterior circulation. As mentioned, the most recent AHA and ASA guidelines give no current recommendations for the prevention of cerebral vasospasm in patients after aneurysmal subarachnoid hemorrhage. To maximize both the efficacy of vasoactive medications and minimize their side effects, other routes of administration have been studied, such as intrathecal nicardipine, which allows for the medication to be delivered right to the site instead of systemically. Intrathecal nicardipine has been shown to decrease mean flow velocities on TCD and reduced angiographic and clinical vasospasm in patients after aneurysmal subarachnoid hemorrhage. The purpose of this study was to determine the safety and efficacy of localized nicardipine release implants for moderate to severe vasospasm following aneurysmal subarachnoid hemorrhage. This study was an international, multi-center, single-masked, phase 2b randomized clinical trial that included patients with WFNS grades 3 and 4 requiring surgical repair and ruptured anterior circulation aneurysm. Patients were randomized to 2 groups. The treatment group received 10 2 millimeter by 10 millimeter nicardipine modified release implants plus standard of care, and this group was compared to standard of care alone. Patients were included if they were 18 to 75 years old, had an FNS grade 3 or 4, had a ruptured anterior circulation aneurysm, had an onset of symptoms within the preceding 48 hours, and if surgical intervention was able to be performed within 72 hours. Patients were excluded for having a subarachnoid hemorrhage due to another cause, if they were pregnant or lactating, if there was any intraventricular or intracerebral blood, if they underwent endovascular embolization, if they had moderate or severe vasospasm to begin with, if they had any known or CT evidence of previous major cerebral damage, if they had a history of malignant brain tumors or metastasis, or if there were any major complications that occurred during surgical repair. The primary efficacy endpoint was the incidence of moderate to severe cerebral angiographic vasospasm between days 7 and 9, where angiographic vasospasm was defined as a greater than or equal to 33% reduction in the diameter of at least one vessel segment by comparison to preoperative angiography. The secondary efficacy endpoint was the incidence of new cerebral infarcts on CT scan 13 through 15 days after or before patient discharge compared with postoperative CT scan. Safety endpoints included the incidences of shunt-dependent hydrocephalus through day 22, bacterial meningitis through day 22, vital signs, ECG, and labs. Statistical analyses were performed as follows. The primary efficacy endpoint and other binary outcomes were analyzed using Fisher-Exact test. Ordered categorical data were analyzed via Cochrane-Mantel-Hansel test. Normally distributed interval data were analyzed via ANOVA. Non-normally distributed interval data were analyzed via non-parametric Wilcoxon rank sum test or rank-based ANOVA. A total of 40 patients was calculated to detect a clinically relevant difference of 50% between the nicardipine and placebo group with 84% power. And all hypothesis tests were two-sided with the standard significance set at less than 0.05. "44 patients were assessed for eligibility and 41 patients were randomized. 21 patients to the treatment group and 20 patients to the control group. 3 patients were excluded as mentioned, 2 did not meet inclusion criteria, and 1 for other reasons, which no further information was given. Overall, the baseline characteristics were similar between the groups. Majority of patients in the control group had an aneurysm of the ICA, while majority of patients in the treatment group had an aneurysm of the ACA. The majority of patients in the control group had a WFNS grade 4, while about half of patients in the treatment group had a WFNS grade 3, the other half 4. About half of the patients in each group had a modified Fisher grade of 3, alluding to equal baseline characteristics for the risk of symptomatic vasospasm. 11 out of 19, or 58% of patients in the control group experienced moderate to severe angiographic vasospasm, compared to 4 of 20, or 20% of patients in the implant group, and this was statistically significant. 6 out of 19, or 32% of patients in the control group experienced new cerebral infarcts on CT, compared with 2 of 20, or 10% of patients in the implant group. Additionally, the authors performed the following exploratory endpoint analyses. The receipt of angiographic vasospasm rescue therapy was less in the implant group, 2 of 20, or 10% of patients, compared to 11 of 19, or 58% of patients, which was statistically significant. Patients in the implant group had a numerically decreased incidence of DCI via CT and decreased mean lengths of ICU stay and hospitalization. Patients in the implant group also had a numerically higher rate of favorable outcome at 1 year, which was defined as an MRS score of 0 to 2. And lastly, mortality was numerically decreased in the implant group. Additionally, patients in the implant group had a lower rate of adverse events, including shunt-dependent hydrocephalus and bacterial meningitis. And on this slide, I've included a table of the distribution of MRS scores between groups. Interestingly, more patients in the control group had an MRS score of 1 compared to the implant group, but overall, more patients in the implant group had an MRS of 0 to 2 at 1 year compared to patients in the control group. The authors concluded that their findings of their study showed that nicardipine implants placed during microsurgical aneurysm repair provide both safe and effective prevention of moderate to severe angiographic vasospasm after aneurysmal subarachnoid hemorrhage. And overall, I do agree with the author's conclusions while acknowledging the following strengths and limitations of the study. Strength of this study include that this therapy is potential novel preventative therapy for vasospasm. Additionally, the study did meet power, and there were similar baseline characteristics between groups, including a similar use of nimodipine, although the authors did not comment on the amount of patients receiving nimodipine or the regimens that they did receive. Limitations include that this therapy is only applicable to patients treated with clipping. In my institution, this therapy would not necessarily be relevant as we mainly treat patients via coiling. Additionally, there is an unclear role or place in therapy with the use of intrathecal nicardipine. And lastly, there was a small sample size and lack of a diverse patient population. And in conclusion to today's presentation, aneurysmal subarachnoid hemorrhage is a high morbidity and mortality disease state that often is followed by serious complications, including cerebral vasospasm, DCI, hydrocephalus, and seizures. Although nicardipine and nimodipine are similar pharmacologically, oral nimodipine is recommended by the AHA and ASA guidelines to prevent DCI. And the study discussed today demonstrated that localized modified release nicardipine implants significantly reduced the incidence of moderate to severe vasospasm after aneurysmal subarachnoid hemorrhage without an increased risk of adverse events compared to placebo. And these findings offer a novel therapy option for the prevention of cerebral vasospasm and potential to decrease DCI, although more data is needed to confirm these findings and the role of this treatment. And at this time, I'm happy to take any questions.
Great. Thank you, Alyssa, for that presentation. If you have any questions, please feel free to unmute yourself or to put your questions in the chat. I'll start, Alyssa. I have a question for you. I think this study was very interesting to me, and I think there's been previous studies using other nicardipine implant brand products that have shown similar outcomes. A small study, but the short-term outcomes that they looked at were very compelling. I think very few of these studies have looked at more long-term outcomes related to functional outcomes. You mentioned that they looked at that a little bit in this trial, but do you think they're looking at the right outcomes for this? If we had larger trials that showed similar outcomes, should this be something that we start doing? What are the downsides, really?
Yes, thank you. So I definitely think that the outcomes from this study were relevant, especially that it did show decreased incidence of vasospasm. I think that, the IV nicardipine and intrathecal nicardipine studies that I referenced earlier also looked at the decreased death and disability due to vasospasm. The two weren't necessarily combined in the study. We looked at MRS, but fortunately that was only at 1 year and not necessarily a more longer term outcome. I think really we just need larger studies, but it is probably to being able to take patients and use the clipping intervention. Not all institutions do that. So I think it's dependent on the institution, but I definitely think it's a good potential option. Just larger studies are needed, specifically looking at like longer disability and mortality outcomes, if that answers your question.
Yeah, I'd like to see that as well. And then did they mention, when they had mentioned the serious adverse events, did they mention what those actually were?
No, the supplementary appendix, I will say, was a little bit disappointing to me, and I wish I had some more information. I know I mentioned like specifically the standard of care and other regimens that patients were on, but unfortunately, we only got serious adverse events, death, and then MRS and the other shunt-dependent hydrocephalus and bacterial meningitis, but nothing really other than that was commented on, which was a little bit disappointing in my opinion.
Yeah, I would have liked to have seen that too, because it was for a small N for each group, a considerable amount were listed as having serious adverse events. So it would have been nice to know what those were. I think those are all my questions. Anybody else have any questions for Alyssa?
Hey, Alyssa, I have a question for you. Great presentation. What did you think about, or what, like, maybe potential future studies about the need for combining these nicardipine implants with oral nimodipine?
And then whatever.
Thank you. I think, like I mentioned earlier, it's definitely a unique mechanism of drug delivery, especially delivering right to the site of administration where we're most concerned about the arterial narrowing. I am surprised that more patients didn't experience hypotension, or if they did, it wasn't necessarily commented on. Maybe it was one of the serious adverse drug events. But I know that typically from what I have seen in my very limited experience, a lot of the times patients can't tolerate the nimodipine dosed at 60 milligrams Q4 hours. And so sometimes we have to cut back to 30 milligrams Q2 hours. So at least just knowing what their regimens were would have been helpful, or at least having that information. But like I mentioned, I think it's definitely unique therapy option where the medication is dissolved right to the site. They did also mention in a previous study where they were looking more at like CSF concentrations and more of the safety studies in animal models. And the drug was completely dissolved within the 21-day period, and it didn't sound like they had to go back in to actually take the implants out. So having that option to do one thing at the time of surgical repair that needs to happen anyways is very interesting as well.
Yeah, I agree. It's hard to foresee like any future studies that don't include nimodipine because it is, you know, the standard of care. Obviously, especially like in the placebo group. But I mean, you do wonder if one day we would get to that point where maybe we could see, because obviously we know that the systemic adverse effects of nimodipine can be limiting in patients, like you said. So it would be interesting to see, or maybe at least if you do have to stop the nimodipine due to adverse effects, that you feel like at least you have another therapy on board to prevent that vasospasm, especially if it does end up limiting or reducing the amount of DCI in the future. So yeah, interesting. Good answers.
Thanks, Megan. Thanks, Alyssa. Any last questions for Alyssa? Okay. Well, thank you for your presentation. That was great. Very interesting topic, and I hope that we do see more literature in a larger randomized fashion looking at this. All right. Our next presenter today is Nicole Castoro. She's a PGY2 critical care resident from New York Presbyterian Hospital, and she'll be presenting to us today a randomized trial that's looking at direct oral anticoagulants versus no anticoagulation for the prevention of stroke in survivors of intracerebral hemorrhage with AFib, otherwise known as the PRESTIGE-AF trial. So Nicole, go ahead and share your slides, and if it's possible to put it in presenter mode, if you know how to do that on your end, that would be great.
Are you seeing my full slides?
Yeah.
Okay.
We can see them.
All right. Well, thank you for that introduction, Kristen. And then I will go ahead and get into the little bit of background information for this article. So for intracerebral hemorrhage, this accounts for about 15% of all strokes. And the annual reoccurrence risk of ICH is about 2 to 8%. Patients with AFib have an increased stroke risk. So our CHA2DS2-VASc score is used to estimate the stroke risk in patients with AFib. And patients have about a 5% chance of stroke if they're high risk and they're not on anticoagulation. About 25% of our ICH survivors also have AFib. And most of these patients were actually anticoagulated at the time of their ICH event. So the optimal prevention management of patients with AFib and previous ICH is uncertain in regards to restarting anticoagulation. In terms of current guidelines, the American Heart Association and American Stroke Association recommend that anticoagulation resumption can be considered in patients with atrial fibrillation at 7 to 8 weeks after their ICH event. And then the American College of Cardiology recommends that anticoagulation resumption can be considered in patients with atrial fibrillation at 4 to 8 weeks after the ICH event. There has been some previous literature trying to delve a little bit deeper into this topic. So the SO-START trial was done to kind of establish if starting anticoagulation is non-inferior to avoiding anticoagulation in our intracerebral hemorrhage survivors who have AFib. So this was a prospective, randomized, open-labeled, parallel group trial comparing anticoagulation to no anticoagulation. They included 203 patients, and the primary outcome they looked at was recurrent symptomatic spontaneous ICH. Between groups, 8% of the patients on anticoagulation experienced that primary outcome, and then 4% of patients in the no anticoagulation group experienced that. However, there was not a statistically significant difference between groups. So ultimately, the articles of the SO-START trial kind of decided that these results were inconclusive, and they did note that the rates of recurrent ICH were lower than they expected as a whole. There was also the APACHE AF trial that aimed to obtain the estimates of the rates of vascular death or non-fatal stroke in patients with AFib with apixaban use versus avoiding apixaban. So this was a phase 2 multi-center open-label parallel group randomized control trial that compared apixaban to no anticoagulation. This trial included 101 patients, and the primary outcome they looked at was the composite of vascular death or non-fatal stroke during follow-up. 26% of the patients who are receiving apixaban experienced this primary outcome versus 24% in the no anticoagulant group, ultimately having a non-statistically significant difference. The authors of this study concluded that there was a high subsequent annual risk of non-fatal stroke or vascular death, whether patients received apixaban or no anticoagulation as a whole. So getting into why the Prestige AF trial was conducted, it was really to determine whether our direct oral anticoagulants, or DOACs, reduce the risk of ischemic stroke without substantially increasing the risk of recurrent ICH in patients with atrial fibrillation. This was an open-label, randomized phase 3 trial that was conducted at 75 hospitals across European countries. This was patients were included from May 2019 to November 2023, and patients were eligible for enrollment at 14 days to 12 months after their index ICH. The DOACs that patients could be using were apixaban, dabigatran, edoxaban, or rivaroxaban. And then the comparator group was eligible at the investigator's discretion to start aspirin 100 milligrams. However, dual antiplatelet therapy was not allowed at the time of enrollment, but was permissible during follow-up. And then these patients were followed for at least 6 months and up to 36 months. In terms of the patient criteria, so patients had to be greater than or equal to 18 years of age. They had a spontaneous ICH, had concomitant atrial fibrillation, an indication for anticoagulation, and a modified Rankin score scale of 4 or less. Exclusion criteria included ICH resulting from vascular malformation or trauma, and the presence of or the plan to implant a left atrial appendage occlusion device. In terms of the study outcomes, so there was co-primary outcomes. So the first one was the first incident of ischemic stroke, and then as well as the first recurrent intracerebral hemorrhage. Secondary outcomes included all stroke and systemic embolism, major adverse cardiac events, cardiovascular mortality, all-cause mortality, and then major bleeding. And then safety outcomes included all events of intracranial hemorrhage and all events of major bleeding. In terms of the statistical analysis that were done, for baseline characteristics, descriptive statistics were used. And then for the primary outcome, testing for DOAC's superiority for preventing ischemic stroke was done first, and then there was subsequent testing for non-inferiority for recurrent ICH. And then Kaplan-Meier curves were used to display the cumulative probability of each event. And then secondary outcomes were analyzed using event rates, and they were calculated per 100 patient years. So getting into the baseline characteristics of the patients that were included in this study, we can see here that the majority of patients had hypertension. Around 20% in each group had a previous ischemic stroke, and then around 6 to 4% had a previous TIA, with 4 to 5% having a previous ICH. We can see that the median CHA2DS2-VASc score for patients in both group was 4, indicating that these patients had an indication for anticoagulation, with a Haslet score of 3. And then the time from index ICH to enrollment was roughly 48 to 49 days between groups. And then there were more patients with lower ICH in the DOAC group. Of note, they did stop enrolling patients with lower ICH after an interim safety analysis from the ARICH-AF trial found that there was excessive risk of recurrent ICH in patients receiving anticoagulation after a lower ICH. And then in terms of the ICH volume, these were ranging from 4 to 3 milliliters between the DOAC and no anticoagulation group. Of note, that is considered a pretty small bleed, where something like 30 mLs would be considered a little bit larger. So looking here at our primary outcome, we can see that for ischemic stroke, our patients in the DOAC group experience this less, with an adjusted hazard ratio of 0.05, and we can see that this was statistically significantly less than our patients who are on no anticoagulation. However, then looking for recurrent intracerebral hemorrhage, we can see that our patients who are restarted on DOACs had a statistically significantly higher hazards ratio of experiencing that at 11.2. We can see here at the bottom, this was a figure kind of showing the intracerebral hemorrhage in relation to their pre-specified non-inferiority margin. And we can see that this kind of lays on the favoring no anticoagulation side. Here we have our Kaplan-Meier curves. So on the left, this represents the time to the first recurrent intracerebral hemorrhage. So in the blue, this is our DOAC group, and then the red line represents our no anticoagulant group. So you can see that for our patients who are on DOACs, they had an earlier first recurrent ICH. And then on the right-hand Kaplan-Meier curve, we can see that this is representing the first incident of ischemic stroke. And almost essentially flipped, we can see that our patients who are not receiving anticoagulation had the first earlier incident of ischemic stroke. Looking at our secondary outcomes, we can see that all-cause mortality was not statistically significantly different between groups. And then we can see that there was more of any major bleeding present in our DOAC group. And then looking at any intracranial bleeding, we can also see that this occurred more frequently in our DOAC group. But then looking at our net clinical benefit, we can see that there was no statistically significant difference between groups. So the author's conclusion based off of these results were that DOACs effectively prevent ischemic stroke in survivors of ICH with atrial fibrillation, but a part of this benefit is offset by a substantially increased risk of recurrent ICH. And they comment that further evidence is needed. In terms of the author's critique, limitations to this study would be the low number of primary outcome events. There was a short follow-up period, so at minimum, patients were followed for 6 months. This was an open label design, and it was also not powered for secondary endpoints. The lower ICH, there was differences between groups, and as we know, lower ICHs are more frequent to have rebleeds. And they were unable to complete an additional analysis stratified by the DOAC type that patients were on. Additionally, patients who underwent left atrial appendage closure at later time points during follow-up were included, which may have affected how frequently they were experiencing ischemic stroke. In terms of strength, one thing that the authors listed was sample size, as well as having an adequate power for primary endpoints. And this was also performed across countries with a homogeneous standard of care, and no patients were lost to follow-up. In terms of my critique, I will say that some of the limitations included the median age of patients in this study were 79 years old, so it might not be as applicable to our younger patient population who is having ICH who has AFib. Also, this was conducted across European countries, which is hard to extrapolate to the United States. I do think that the multiple types of DOACs used is a limitation. Just would like to have some information regarding the specific type of DOAC that was used. I also think that the limitation of really a majority of these patients had smaller bleeds, which I think limits the application of these results to patients who have had larger bleeds. I also think the limited number of primary outcome events could have been some of the reason for some of the confidence intervals that we're seeing. In terms of strengths, I do think that excluding patients with vascular malformations to limit confounding factors was a strength, as well as excluding patients with left atrial appendage closure at the time of enrollment, although I would have loved to see that extended during the whole study. And then I think having co-primary endpoints really allowed for a comprehensive outcome assessment for restarting DOACs in these patients. I also think the secondary endpoints that they used highlighted the safety and efficacy, as well as testing for superiority and inferiority for recurrent ICH was a strength. In terms of the clinical interpretation, I think patients presenting post-ICH with a history of AFib are at risk for recurrent ICH and for ischemic stroke. Our current guidelines recommend that the resumption of anticoagulation can be considered at 4 to 8 weeks after ICH. Previous literature has not shown whether there is a benefit to anticoagulation use in regard to recurrent ICH, vascular death, or non-fatal stroke. And this study shows that there is a benefit to anticoagulation for the prevention of ischemic stroke. However, there is an increase in rate of recurrent ICH. For patients with atrial fibrillation who have survived ICH, a multidisciplinary discussion should take place regarding the need for anticoagulation in order to prevent ischemic stroke. So in terms of future directions, I think this study does not provide definitive guidance about the best approach for managing these patients. And I think there's a need for future studies to identify patient characteristics that may favor anticoagulation use versus no anticoagulation. And with that, I'll come to an end to my presentation, and I'm welcome to answer any questions.
Thank you, Nicole, for that presentation. We'll open it up to the audience for any questions. I'll start, Nicole, based on your last slide and kind of your summary and next steps that are needed. You're right in that the study doesn't really make a blanket recommendation for resuming DOACs or not, and really highlights the need for an individualized approach. And you talk about thinking about individual risk factors or characteristics that we should think about in future studies. So what should we study? What patient characteristics should we look at or think about in future studies to try to answer this question of resuming or not?
Yeah, I think something to look at is some of the factors that we are known to be associated with already high risk of thromboembolism. So things like, our patients who have even higher CHA2DS2-VASc scores. I think I would have liked to see, granted that the median that they presented in both groups was 4, but as patients got higher than that, was there an association one way or another, which could benefit? I also think having it more stratified out by site of the bleed. So if we could see more about our lobar ICHs, as well as consideration for the volume of the ICH as well, is kind of the big things that I'd like to see.
Yeah, I agree with you. I think there's a lot of things we could look at that weren't looked at in this study. It'd be nice to have future studies that do look at some of the things that you mentioned. If anybody has a standard practice at your institution that you want to share as well with regard to this patient type, please go ahead and share that as well. It'd be interesting to hear what other places are doing. Any other questions from the audience?
I'll jump in with a question. What factors do you think might, patient-specific factors might prompt you to decide between anticoagulation versus no anticoagulation for a patient like this?
I think something, when we're at that point after a patient has had an ICH, having discussions about whether to restart it or not, I think things that make me more hesitant, are patients who have a larger volume of bleed, especially if they had a lower CHA2DS2-VASc score to begin with. Granted, they will still have an indication for anticoagulation if we're having a discussion. And I think patients too who are, of older age, we know they have a higher chance of reoccurrent ICH. So I think those would all be things that would be kind of in the discussion.
Yeah, I also think about patients with, especially like in some of the patients that I see here in Philly are like medication compliance as well. For example, like their blood pressure medications, right? So like if their blood pressure, if they frequently come in with hypertensive urgency or issues surrounding that, that might also put them at higher risk for recurrent ICH too, as well as obviously like, were they on anticoagulation when they had the hemorrhage initially, things like that. There's some other things that I usually think about. But sort of to answer your question, Kristen, like we don't really have a standardized, protocol. I don't think this is something that, in my experience, really can protocolize just yet because it is so patient specific. And then, of course, also like timing of starting it is like the next big question, which obviously wasn't really answered by this study, but it's interesting to see their time points.
Yeah, same for us. Very individualized approach, which I think is probably the most common approach across institutions. But again, if anybody has any different practices, please speak up. I think the other thing that struck me in the study, Nicole, which you mentioned, is predominantly a European population. And when you look at the ethnic groups included, it was, I think, 97% and 95% white population in both groups. When we think, based on suggestion and the literature, that there's potential racial and ethnic disparities and background inherent risk of ICH. So kind of taking that literature into consideration, do you think we could apply this study to a more largely diverse or ethnic population?
I don't think so. I do think that is something very important to consider. Granted, like this was, it was across multiple countries, but it was multiple European countries. And I think that is true. Like we do have a little bit more of a diverse patient population here in the United States. So I would be hesitant to really apply this to our whole patient population just yet.
Yeah, and I think that's another thing I'd like to see in a larger study is more ethnically diverse groups included, just knowing that there is potentially a decrease in that inherent risk of ICH that may impact some of the outcomes we see here. But that really struck me in this study as something that stood out to me. Any other questions or comments from the audience for Nicole today? Okay, well, hearing none and seeing none in the chat, I just wanted to thank both of our presenters again for taking the time to put together these slides and present to us today, and for your answers to all of our questions. We really appreciate you guys joining us today, and thank you everybody for joining in general. We look forward to seeing everybody in our next Journal Club next month. Thanks, everyone.
Great job. Thank you.